Welcome to Chapter 20. We're going to be talking about the heart, or cardiology, today. This is only a 49-slide lecture, but it's extremely important, both for your future career and also for your own health. So there's a few basic things that you're going to absolutely have to know to complete this chapter successfully, and I'll be pointing those out as we reach them. First off, here is a YouTube video. So if you'll simply copy this link and watch this, it'll talk about function of the heart and give you a graphic demonstration of the blood flow. The human heart has been romanticized through history as the center of our love and our emotions. We know now that it's actually the brain. It's just that on Valentine cards, brains look sort of creepy, so we still stick with the heart. We tend to put our hand over the left side of our chest when we pledge allegiance, meaning that we're going to, uphold something with all our heart. Well, the ironic thing is your heart's actually in the center of your chest. It's not that big, roughly a pound on an average-sized man. It's about the size of your fist, if that gives you any relative sense of size here. If you look at this, it beats up to 100,000 times a day, and your heart does so almost perfectly until you die. So the blood is going through about 50,000 miles worth of blood vessels. If you were to lay all your arteries and veins and capillaries end to end, you could stretch them around the equator twice, which is one of those little factoids that amazes geeky brains like mine. Again, I don't really care that you memorize these factoids. I just give them to you to give you a sense of scale. We talked about in 141 how your brain plays favorites and builds special vaults or enclosures for its most important organs. We talked about the skull being built around the brain. Well, your heart is not quite as well protected, but it's still fairly second in ranking here because you've got the ribs, you've got the sternum, or your breastbone, and you've got your vertebral column that surround the heart. Luckily for us, it's not a rigid container because that flexibility is going to allow some give when, for example, you're hit with sudden trauma. If it were rigid, it would actually go ahead and fracture, and then you would be worse off. The flexibility also allows a good case of CPR to mimic the outflow of the heart up to about 80%. So if you did not have that flexibility that's produced by the combination of cartilage with that bone, then you would have no way for a CPR to be successful. Remember that the heart lies within the mediastinal space. If you need to go back to, I believe it was chapter 1, we talked about the various divisions of the body cavities. So the mediastinal cavity is going to be located right in this area right here. And again, notice that the heart is going to be contained in that. Go back and look up, if you have to, the contents of the mediastinal cavity. You'll see things like the trachea, the esophagus, what they refer to as the great vessels, meaning the vena cava and the aorta, and then the heart itself. And remember that all of this is contained within the thoracic cavity. So you have the thoracic cavity containing the lungs and the mediastinum, and then you have the mediastinal cavity containing the heart located inside the pericardial cavity. One of the first things you need to visualize as you go through this chapter is you actually have two different circulations happening in your body at one time. Blood is leaving the right side of the heart and going to the lungs. Blood is leaving the left side of the heart and going to the rest of the body. So the left side of the body is systemic and the right side is pulmonary. Now, you probably learned in grade school that arteries carry blood with oxygen and veins do not. Okay, forget that. You really can't go by that. Don't ever repeat it anymore. So what you're going to be saying from now on is arteries carry blood away from the heart. Because what you're going to find, and don't get hung up on it now, hopefully you'll understand it shortly, but systemic arteries will be carrying blood that has a higher level of oxygen. However, pulmonary arteries are going to be carrying deoxygenated blood because you're actually carrying the blood from the heart to the lungs to get the oxygen. I never have liked these types of diagrams because to me they're just visually confusing. But what they're saying here is that the pulmonary circulation and the systemic circulation are happening simultaneously. So in other words, while you've got this circulation going, you also at the same time have this circulation going. So we're going to be learning that you've got 4 chambers to the heart. And so the bottom chambers represent the ventricles. And at the they beat simultaneously. The atria are up here. So when the atria beat simultaneously, they're actually ejecting blood into the ventricles at the same time. When the ventricles beat, they're actually ejecting blood into the pulmonary and the systemic arteries at the same time. So you have to kind of visualize, first off, the top chambers of the heart's contracting and pushing their blood out. And then you have to visualize the bottom part of the heart contracting simultaneously and pushing the blood out to their respective arteries. We're going to be talking about this a lot more in chapter 21. 21 is all about blood vessels, but we have to have these definitions understood before we go any further. Arteries carry blood away from the heart. As they get smaller and smaller going away from the heart, they're going to branch into arterioles. So an arteriole is simply a tiny artery. The arterioles are going to turn into capillaries, and the definition of a capillary is a blood vessel that's thin enough that exchange happens between the blood or the plasma and the interstitial fluid around the vessel. The capillaries then thicken up and turn into venules, which are small veins, and then they get larger and larger until they become the veins, which end up going back into the heart. Let me try to draw something that I normally draw in class. And we're going to make it a little bit more complicated, one of these shortly. Leaving the heart, and now this is going to be for the systemic and the pulmonary circulation. We're just going to be talking about blood vessels here. You're going to have the arteries, and they're going to be very thick-walled. We're going to start out, you'll be learning later, with the aorta. And then they're going to thin up into arterioles. And then the arterioles are going to get thinner and thinner until they become capillaries. Then at the end of the capillary bed, they're going to become venules. And then the venules are going to get thicker and thicker in their wall until they actually make veins. So forgive the lack of artistic ability. It's not even great on a whiteboard, but it's even worse on an iPad. But what you're looking at here, you've got your arteries, arterioles, capillaries, venules, and then finally the veins. Now we'll get back to circulation shortly, but let's go ahead and continue our discussion about the heart and its location and the composition. The heart is surrounded by a sac referred to as a pericardium. The pericardium, remember, is going to be a serous membrane, and as such you're going to have 2 different layers. You're going to have the visceral layer, which is on top of the heart itself, and I'm going to give you another name for it in just a moment. And then you have the parietal layer, which is lining the very tough fibrous part of the pericardium. Now, in between these 2 layers, you actually have a theoretical space that is going to be filled with pericardial fluid. So looking at the individual parts of the pericardium then, you have this very fibrous sac, which is made out of a dense connective tissue, and it's lined by the thin serous membrane of the parietal pericardium, and then the visceral pericardium, and make sure you know this, you're almost guaranteed a test question, is going to be the same thing as the epicardium. Remember, epi means above. So the epicardium is the visceral pericardium, and it's simply a layer of serous membrane that is tightly attached to the surface of the heart itself. The pericardial fluid is being continuously formed and continuously filtered out. So at any given time, it's actually a very tiny amount, but you're producing it on a constant basis. The purpose of this is sort of a clear, slippery fluid, very thin, very watery. And the biggest purpose of it here is to eliminate friction between the heart and the pericardial sac. Again, that heart is beating upwards of 100,000 times a day. And any two surfaces rubbing each other is going to produce friction. So that pericardial fluid, you can think of it as a silicone layer that's going to eliminate the fluid. Therefore, you won't self-combust during the day from generating too much friction. What you're seeing in this photograph is you're looking here. This is a lung. This is another lung. And you're looking at a slice of the heart here between the lungs, where it's peeking out from the mediastinum, and this white shiny material is that very tough pericardial sac. So a couple of things that can go wrong here. So there's something called cardiac tamponade. That's when you have a filling of the pericardial sac with some type of fluid. Typically we think of it as a hemorrhage. Say someone's hit a steering column, they've had some sort of blunt force trauma, and they're going to hemorrhage into the pericardial sac. And the good news is that the sac is going to provide pressure that's going to, at some point, eliminate the hemorrhage. The bad part is that the pressure of the fluid inside that sac is now going to be too much to allow the heart to expand and beat. So you'll actually end up having heart failure due to the inability of the heart muscle to pump. So that would be cardiac tamponade. Restrictive pericarditis, well, first off, let me give you the definition here, just pericarditis. Remember that itis always means inflammation, so pericarditis then is just anything that causes inflammation of the pericardial sac. That might be a viral infection, that might be some sort of Lyme's disease, anything like that. Restrictive pericarditis is when there's so much scar tissue that it also is going to prevent the heart from being able to expand enough to actually pump. Actually, relatively simple to treat. All they'll do is go in there and make an incision into the pericardium and leave it open to allow the heart to do its job and beat efficiently. It's very important you know the layers of the heart. The epicardium, I've already mentioned to you, is simply the visceral pericardium, simply a serous membrane, very thin layer. It's attached to the myocardium. Hopefully you'll remember that myo is a prefix for muscle. So the myocardium is by far the thickest layer of the heart. So the endocardium is another serous membrane, and it's going to be the lining of the heart. So you've got the epicardium, the myocardium, and then the endocardium. There are 4 chambers or rooms to the heart. The 2 on the top are referred to as the atria, which is plural for atrium. That means preceding room or waiting room. Perhaps you've heard the term as far as the atria of a building, atria of a church, for example. So you've got the right atrium and the left atrium. The word ventricle means belly, and we have the ventricles down here, and we have the right ventricle, and then we have the left ventricle. So those are the 4 chambers of the heart. Now, I mentioned to you earlier that the left side of the heart is sending blood all the way around the body, to your fingertips, to your scalp, and your toes. The right side of the heart is only sending blood to your lungs. So, if you picture, and again, really bad artwork here, if you're sending blood from the heart to the lungs, that's not very far. So the muscle is not having to work that hard. However, if you're sending blood all the way to your fingertips or all the way to the toes and back, that's a lot further. The muscle is going to have to work a lot harder. Now, we've talked about muscles and how they grow and how they develop with increased workload, and it's the same thing here. So we're talking cardiac muscle. So you can always tell on a cut section or on a diagram of a heart which side is right, which side is left, even if you knew nothing about anatomic position or anything like that. So again, up here, you may not be able to tell because that's our atria, but let's look down here. Here is the septum, or the dividing line between the two chambers. So we've got a ventricle here and a ventricle over here. So if you look, the width of the muscle there and the width of the muscle here, it's much thicker right here. So therefore we know that this is going to be the left side of the heart and this is going to be the right side of the heart. That means this is the right atrium. That means this is the left atrium. That means this is the left ventricle. And there's the right ventricle. So again, look at the thickness of this wall compared to that. Because again, the heart, when it's sending blood to the lungs, it's not having to work nearly as hard. So the myocardium of the left ventricle is 4 times thicker and 4 times stronger than the right ventricle myocardium. You need to be pretty well acquainted with what's on this page right here. The atria, again plural for atrium, these receive the blood. They're thinner walled, and the division is going to be the intraatrial septum. You have an auricle, a little ear-shaped flap that sits on top of the heart on each side, and those are on top of the atria, and they expand when they fill up with blood. It just gives it a little extra holding room. The word auricle means ear, and when you look at this on a heart, it's going to look like a little elephant ear. You have little linear pectinate muscles in the atria. So the ventricles on this side, these are the ones that have the much bigger job of actually pushing the blood into the arteries, both the aorta and the pulmonary arteries. They're much thicker walled. You have the interventricular septum, and you have these large ridges of muscles referred to as trabeculae carneae. You also have these little bump-like muscles that are called the papillary muscles. The word papilla simply means hill. Attached to those papillary muscles are chordae tendineae. The chordae tendineae actually attach to the flaps of the valves, so that when the heart contracts, the valve doesn't go backwards. It holds it going in one direction. Now, I've got some more pictures of that in just a moment. So make sure you know the difference between these 3 items. Make sure you can localize them on a model or on a diagram. Okay, this is a pretty important picture because you're going to be seeing something very similar to this on an exam, either in lab or in lecture. And you're going to need to know quite a few things on here. First off, I've told you, now this is not a great example because I'm not wild about the way they drew the ventricles, but as far as the width of the myocardium. But to orient yourself, don't worry about the color or anything else. First off, look for the wall of the ventricles. So let's look at this. Let's divide it in half. So we know up here we're going to have the atrium, and down here we're going to have the ventricles. Now, again, this is not a great example of it, but look at the thickest part of that wall and the thickest part of that wall. And this is thicker over here, so we know that this is the left ventricle and this is the right ventricle. Correspondingly, this is going to be the left atria right here, and then here is your right atrium over here. So, what you're seeing in here, these big ridges of muscles. Behind over there you'll see the same things. Those are the trabeculae carneae muscles. These little hills, those are the papillary muscles, and they are attached to these strings called chordae tendineae. These are actually referred to as heartstrings in your book. So there's your little papilla, your papillary muscle, and there's your string. and what you're seeing right here is the valve of the heart. So these valves are one-way valves that keep blood flowing in one direction. You're going to have to know that this is the aorta, and that this structure right here is a pulmonary trunk, which you can also call the pulmonary artery, that it is split into right and left right there. So we're going to be talking about, it's very important that you know the blood flow through the heart, and I'm going to give you a big diagram about that. I've got one posted under course documents too, but I'm going to also draw one and walk you through it. So what's going to happen here, now you may have figured out what's in blue here is representing the right side of the heart, and what's in red is representing the left side of the heart. So you've got blood that's going to be coming into the vena cava, and you're going to have to be learning that you have the inferior vena cava getting blood collected from the lower part of your body, and then the superior vena cava, which is collecting blood from the upper part of the body, and it's dumping blood into the right atrium. The blood's going to flow through the atrioventricular valve into the right ventricle. That's going to flow through the pulmonary valve, out the pulmonary arteries to the lungs. That blood's going to flow back through the pulmonary veins into the left atrium, which is going to flow into the left ventricle. The left ventricle is going to contract and push blood out the aorta to the rest of the body. Now, I realize I just made a big mess on your screen here, but you can find this diagram under course documents. You can find something very similar in your textbook, and I want you to be able to visualize blood flow. Now, what I just told you, though, picture following a red blood cell going all the way through, making the loop of the circulation, because remember that the two atria are actually beating simultaneously. So while you've got blood going from the right atrium into the right ventricle, you also have blood going from the left atria to the left ventricle. And then conversely, when you've got the ventricles contracting, you've got blood flowing into the pulmonary artery, and you've got blood flowing into the aorta. So again, top contracts, bottom relaxes, bottom contracts, top relaxes. Okay, forgive me because I just rearranged some of your slides. So this is actually about 6 slides down in your PowerPoint that's under course documents. But I just wanted to show you here what we're talking about here. These are some chordae tendineae. You've got your papillary muscles. And I wanted to show you that these, again, are the heartstrings that will be holding these one-way valves from being pushed backwards, because the heart is going to be generating a fair amount of force to drive this blood in one direction only. Speaking of valves, let's go ahead and name these. Again, these valves are keeping the blood going in one direction, and there are 4, and you need to know multiple names because you never know what particular name that someone's going to be using. So the atrioventricular, just like it sounds, is going to be the passageway between the atria and the ventricles. So you've got a right AV valve, which is also called the tricuspid. The word cusp means leaf. So, you know, think about little leaflets here that compose this. So a tricuspid valve is going to have 3. The left AV valve is a bicuspid valve, but it only has 2, and you see this on this picture here. So the bicuspid is simply going to be 2 flaps that come together. So here we have another word used for the left AV valve, and that's called the mitral. You probably have heard that phrase before. It's not an unusual thing to have a little mitral prolapse or mitral regurgitation, a very common thing. In fact, I have it myself, where when the left ventricle contracts, it actually pushes the valve backwards into the atria, and you have a little bit of blood that should not be going backwards that gets sent back into the atria instead of being sent back to the aorta. Most of the time it's asymptomatic. It can be progressive enough where it requires heart valve transplants. So make sure you know for the exam, the right AV valve, the right atrioventricular valve, is also called the tricuspid. The left AV valve is also called the bicuspid or the mitral. Know all the names. Now, the pulmonary and aortic valves are both known as this semilunar, which means half moon. So I never can quite see how they get those names for that one in particular, but the pulmonary valve leaves the right ventricle, and the aortic valve leaves the left ventricle. So this goes to the pulmonary vein, and this one goes to the aorta, just like you would think. Here's another diagram, again showing you the layout of these valves, and you can see pretty clearly the tricuspid arrangement versus the bicuspid. Then the semilunar valves down here, again, I guess the half moon thing they're looking at right there, but it takes more visual imagination than I have. These valves, when they shut, they actually make a sound. And those give you most of the heart sounds that you hear when you're listening with a stethoscope. So I do want you to know this, that the valves closing give you the heart sounds. So the heart, when you listen at it, is generally characterized as a lubbed up. So it's lubbed up, lubbed up, lubbed up. The lub part is called S1, and it's caused by the closing of the atrioventricular valves. And the duct part, the S2, is caused by closing of the semilunar valves. Now, every now and then, if you have a very thin patient or a patient with a very slow heart rate, let's say some extreme athlete, you might actually hear S3 and S4, and those are simply from blood flow, but you won't always hear those at all. Prolapse, by definition, is when the valve goes backwards into the preceding chamber. It creates an insufficiency, which simply means that the valve is not doing its job. It's leaking, basically. And that leaking is referred to as regurgitation, and it produces something called a murmur. So a murmur is an abnormal sound caused by regurgitation of blood, or backflow of blood, which is often secondary to prolapse of a valve. There are many apps and many websites you can find, and I hope you take time to listen to them, that will actually demonstrate the various sounds of the valvular diseases. There's another word. Let me go ahead and write it down here for you. Stenosis. A stenosis is a narrowing of any circular structure. You can have a stenotic trachea, esophagus, or anything, but in this case, when you talk about a stenotic valve, that valve has narrowed, which means that blood is going to have to be pushed through there with a lot more force, which means the ventricle or the atria behind it, usually ventricles, because it's usually an aortic or pulmonic stenosis. Those chambers of the heart have to work that much harder, and it will often lead to a much thicker heart chamber. So I have a friend who has an aortic stenosis, which has led to what they refer to as concentric, which means circular, hypertrophy of that ventricle. So it's made that ventricle wall that much thicker because it's having to squeeze to push blood through that valve. So again, listening to hearts, or auscultation, simply means listening. It's really an art form. It's a lot of fun. There's a tremendous number of things you can tell without ever having to use an echocardiogram or an EKG, anything like that, simply by listening. You can hear the whooshing, you can hear all sorts of dropped beats representing an arrhythmia or respiratory sinus arrhythmia, anything like that. So before you learn to even start to interpret, when you get into a professional program, any of the advanced technologies such as EKGs and echoes, you need to learn to listen, because your ears can tell you a great deal. So please take some time, listen to those programs with the heart sounds, listen to the variations. I don't expect you to be able to distinguish any of them at this point in your education, but I just simply want you to be exposed to them. This is simply a picture I wanted to put in here to walk you through it again, since this is using a specimen and not a diagram. So again, look at your atria, then look at your ventricles, look at the thickness of the wall. So we know that this is left, we know that this is right, we know therefore this is the right atria, we know that this is the left atria, Then you have the right ventricle, left ventricle. Therefore, we know that here is your bicuspid or mitral valve, and here is your right AV or your tricuspid valve. So again, you can see the little chordae tendineae in here. You can see the little papillary muscles. You can see over behind here, you can see some of the trabeculae carneae. Okay, this slide gives you just a rough idea of the pathway of blood through the body, and I'm going to draw it for you in a circle pretty shortly. But again, you've got the inferior and superior vena cava collecting the blood from the body, sending it into the right side of the heart. So this pretty much is the right side going through the lungs. It leaves the lungs, going through the pulmonary veins, and it arrives at the left side of the heart. And the left side of the heart, you've got blood going from the atrium through the bicuspid or left AV valve into the left ventricle, which pushes blood through the aortic valve, which sends blood into the aorta, and then the aorta sends blood through the systemic arteries out to the entire systemic circulation, basically your feet, your hands, your skin, your viscera. And then it recycles all over again. Now bear with me, because this is going to be a little bit difficult to get this done on an iPad screen as opposed to being on a whiteboard in a classroom. But I really kind of want to walk you through this here. So let's start with blood flowing from the upper part of the body into the superior vena cava, and from the lower part of the body into the inferior vena cava. So we've got blood arriving at the vena cava. That's going to be going into the right atrium. That's going to be going through the tricuspid valve. Blood that passes through the tricuspid valve is going to end up passing into the right ventricle. That blood will flow out through the pulmonary valve. It's going to be going into the pulmonary arteries. It's going to flow into, and I'm not going to break this down all the way into arterioles and venules. Hopefully you'll be able to fill that in on your own. Into the lungs. Then into the pulmonary veins. That's going to flow into the left atrium. That's going to go through the bicuspid valve. From there it goes into the left ventricle. Flows through the aortic valve. There into the aorta. Systemic arteries. Again, I'm bypassing arterioles and venules here. Capillaries. Veins, and then that's collected into the vena cava. Now, I've had students before get totally confused if I give them a partial diagram, but instead of going in this direction, it goes in that direction. Please don't marry a diagram. You need to be able to figure this out. I really would like you to get familiar with this enough that you can just sit down and write this out. Again, if I had more room here, I would have included here arterioles, right here, and then venules. Actually, I'd have pulmonary capillaries and then the venules right there. And then again, I could have the systemic venules right here and the systemic arterioles right there. But again, be very well versed with this flow of a drop of blood through the heart. Okay, let's look at the heart on the outside. Now, I'm not going to require you to know, for exam purposes, the coronary circulation, which we'll be talking about in just a second. That's going to be the vessels going around the heart that you see, for example, right there. If you go to the grocer or the butcher, you can actually get a beef heart. In fact, you might want to do that. I use a lot of fresh beef hearts and pig hearts in lab, and you can actually see very well the veins and the arteries as they go through here. Just while we're here, a couple of things to orient you here. One thing I did not point out for you, the tip of the heart is referred to as the apex. So you can also find the apex typically, unless you're looking at a formalinized sheep heart that's been mashed out of any sort of recognizable shape. Typically, you're going to find the left side of the heart over here, and then the right side of the heart over there. So, look for your apex. Here, you see the little flap I referred to earlier as the auricle. Those are the little ear flaps, ear-shaped flaps they're expandable, and they're lying right on top of the atria to give the atria more room to handle blood. You'll see on these different views here of the heart, this side is looking at the front of the heart. If you're standing there, for example, you have someone facing you, this is what you'd actually be seeing. Here again is an auricle, and here is the left auricle over here. Here's your apex, so we know that this is the left side. They refer to these grooves as the sulci, and you'll see a lot of fat. It's very normal to have this coronary fat to some degree on every healthy heart. Obviously, you wouldn't want too much of it, but here's the aortic arch. And from there, you'll see the various arteries branching off to go to the different areas. Here's your pulmonary trunk going to the lungs. And here's the vena cava, where you've got blood coming in. You don't see the inferior vena cava, but it's coming up to the back side that's putting blood into the right atrium. Again, here's the back side of the heart. You see that epicardial fat or pericardial fat. The coronary circulation are the blood vessels that actually provide the blood supply to the heart itself. So these, well, I won't say all of them, but quite a few of these arteries and veins are visible when you look at the exterior heart. And when the heart itself is relaxed, that's when the vessels are open enough to actually bring their blood. The arteries start out at the aortic sinuses. An aortic sinus is simply a dilated area at the base of the aorta, and so you have the coronary arteries that come off of that. The veins gather up the basically used blood, and they deposit it in what is referred to as a coronary sinus, which then is delivered into the right atrium to be recirculated through the lungs. When the coronary circulation is impaired, it's going to deprive the heart muscle of blood flow, and that is what is known as a myocardial infarction. We'll talk about that a little bit more later. Basically, it's a heart attack. It's the result of the cardiac muscle from being deprived of blood flow and therefore oxygen. Now again, for our purposes, I'm not going to have you be able to label this, but simply looking at the coronary circulation, it's divided into the right and the left coronary arteries. They branch into the marginal arteries and the circumflex artery, and then what's referred to as the interventricular artery and the posterior ventricular artery. Now, there is what is referred to as an anastomosis between the posterior and anterior interventricular arteries, and I just wanted to explain what an anastomosis is. An anastomosis you can think of as another way to get there. In other words, let's say you've got two arteries going in the same direction, of course. When they meet this way, what's going to happen, if something happens to block that pathway, then the blood is from going down this pathway can alternate over to there. And that's a safety mechanism. It's an anastomosis. Now the word itself, anastomosis, can be used to describe anything from abnormalities to a normal structure. So the word itself simply means a joining. I always use the description, an example of the Washington Beltway. You can get into the downtown DC area from 195 or 395, but if you have an accident on one of the, let's say you've got a 195 is blocked, you simply can go down 395. So that's because you have these anastomosing ways to get into the city. I always thought this was a fascinating picture. What this is showing is the vasculature of the heart with all the other tissue sort of dissolved away. So you don't realize how intensively intertwined all these capillaries are, and all the little arterioles and venules, and then arteries and veins as far as into the muscle of the tissue. But this gives you a good example of it. So here's a couple of words you need to know. The word ischemia simply means lack of blood flow. If you were to take a rubber band and wind it tightly around your finger, then your fingertip will become ischemic because you've lost the blood flow. Now, when that tissue starts to die, that dead area is referred to as an infarction. So what this picture is showing over here is an area of infarction that has been caused by a blockage of this blood vessel. And so that's referred to as a myocardial infarction, also known as a heart attack. You can have a blockage of a blood vessel resulting in myocardial ischemia, and if the blockage is corrected quickly enough, then blood flow is restored. There's not permanent damage. So that's why seeking treatment quickly and taking an aspirin at the first sign of a heart attack can be so life-saving. Now, while we're on the topics of blood flow, I want to talk about the two passages that are open as a fetus, but they're closed as the adult. The first one is referred to as a foramen ovale, and you need to know this. This is an opening between the right atrium and the left atrium. And what it's doing is allowing blood to bypass going to the lungs. When you're in utero, you do not need to breathe air. So therefore, there's no reason for blood to go through that pulmonary circulation. So you're basically bypassing the right ventricle and the pulmonary circulation, and you're going directly to the aorta. So make sure you know, for testing purposes, the foramen ovale is an opening in the interatrial septum between the right atrium and the left atrium. It should close at birth, and there's a little tiny piece of scar tissue that's left on the wall of your atria, referred to as a fossa ovale or fossa ovalis. If it's not closed at birth, then they're not going to immediately do a neonatal surgery. They might give it up to a year, depending on severity of clinical signs. The second passageway I was referring to is referred to as the ductus arteriosus, and you need to make sure you know this one. This is an opening between the aorta and the pulmonary artery. So once again, the whole purpose of this is to let you bypass the lungs. So at birth, this little passageway should constrict down and close up. Now this model is showing what's referred to as a patent ductus arteriosus, which means one that did not close at an appropriate time. There is a group of birth defects called tetralogy of Fallot, and they're all cardiac issues, but two of those would include a patent ductus arteriosus and also an unclosed foramen ovale. Again, the point at which they decide to go in and do cardiac surgery on these babies is going to depend on the severity of the clinical signs. They sometimes will wait until the infants are around a year of age if they're doing okay otherwise. This was a case, and I simply put this in here, it's unrelated to what we were just talking about, except that it is a birth defect. This baby was in the news a couple of years ago. She was actually born with her heart on the outside of the chest. And what you're seeing here is simply the heart encased in the pericardium and basically skin. What they did to correct this is they put in stretchers in her chest, on her chest wall and the sternum, under the sternum, to gradually expand enough room that the heart could be safely tucked inside the chest and then the chest wall closed. So I guess today she's probably several years old, and the last I heard she's doing quite well. Let's switch gears here and go into a little bit of histology and cytology. Cardiac muscle, we talked about in Chapter 4, is a tissue type, and it's got several unique things that you need to know about. First off, it has a very unique ability to set its own rhythm. Remember, we talked about action potentials, and cardiac muscle tissue has its own ability to generate action potentials. It does not have to get the impulse from a neuron. So these action potentials are self-generated. It's referred to as autorhythmicity or an automaticity. So remember that cardiac tissue is under control of the autonomic nervous system. Autonomic means automatic. You've got no control over that. The heart rate and the strength of contraction will be increased by stimulation of the sympathetic nervous system. Make sure you know that. And it's going to be decreased by the parasympathetic system. So parasympathetic, remember that's your rest, nest, and digest. Your heart rate will slow down. The force of contraction will slow down, your blood pressure will decrease. The other unique thing about cardiac muscle tissue is it has a type of cell junction referred to as an intercalated disc, and that's what you're seeing, these little perpendicular marks here. So those allow the cells to join very tightly together. They're not disrupted by the force of contraction, and it also allows a very rapid transmission of an action potential from one cell to the other, because it's critical that all these cells contract simultaneously. Otherwise, you'd have basically a bag of worms, which is actually what you have when you have cardiac fibrillation, which, you know, cardiac fibrillation is basically this big quivering mass of heart muscle, and that has to be corrected. Sometimes it's converted medically, and sometimes it's converted with using electric shock paddles. Cardiac muscle tissue also has a big difference from skeletal muscle tissue in that it has what's known as a plateau period. Remember the steps of the sliding filament theory. I know you guys all enjoyed that. But basically what happens when calcium ions leave the sarcoplasmic reticulum to bind to the heads of the troponin to cause a rotation of tropomyosin, remember the actin and myosin filaments, at the end of the contraction, what happens is the cross bridges break down, calcium is released and goes back into the sarcoplasmic reticulum. But what happens is there is a plateau period which lengthens the time that it takes before this calcium goes into the sarcoplasmic reticulum. What that does, it makes it impossible for the muscle cells to go through the the contraction and relaxation phases any faster. So remember, skeletal muscle tissue, you can have a contraction, relaxation, contraction, partial relaxation, contraction. Again, you can end up with what is known as a wave summation. So skeletal muscle can have a wave summation, and it can give you a partial or a complete tetanus. But with the cardiac tissue, again, you've got contraction, relaxation. It's going to go through the entire cycle. It cannot contract any faster if it wanted to because of this plateau. So because it's simply not ready to contract right here, because the calcium is still not back into the sarcoplasmic reticulum. So that gives you what is referred to as the trepa, or stepping stone configuration. That prevents your heart from going into this spasm of contraction. That would not be very pleasant. So I've told you that muscle cells of the heart have the unique ability to generate their own action potentials, and that's referred to, one of the terms, as autorhythmicity. So what you have are certain cells in the heart that have the job of generating action potentials that will control when the heart contracts and when it relaxes. It's going to be carried through the muscle of the heart by what's referred to as a conduction system. The conduction system coordinates the activity of all the muscle cells to make sure that they're relaxing when they should and when they're contracting when they should. You need to know this. The normal cardiac pacemaker is referred to as the sinoatrial node. It's simply a collection of cells located in the right atrium, and they set the heart rate. So it's referred to as the SA node, and that is a normal cardiac pacemaker. And the rhythm that it sets is referred to as a normal sinus rhythm. Now I want you to know the steps of this conduction pathway. So the impulse is generated by cells in the SA node. So let's draw your heart here. And let's say that your SA node is up here. Then your intranodal pathway is simply the connection of fibers that runs to the atrioventricular node. From there, it goes through what's referred to as the AV bundle, again, just a collection of fibers. Then it branches into what's referred to as the bundle branch. And then those branch again into what's referred to as the Purkinje fibers. And then the Purkinje fibers go directly to the papillary muscles, and they help control those valves when the blood's going to be passing through them to keep, again, when the heart contracts, it keeps those valves from prolapsing backwards. So let me give you a couple of definitions here. Bradycardia is when the heart rate is too slow. Tachycardia is when it's too fast. Ectopic pacemaker. The word ectopic means something is out of place. You may have heard the term before, ectopic pregnancy or tubal pregnancy. It's just something's not in the correct spot. An ectopic pacemaker is when you've got a rogue collection of cells that have sort of mutinied and taken over the SA node, and they're generating an abnormal heart rhythm. And that's when people end up with pacemakers being implanted to generate their own controlled rhythm. One more term I wanted to give you, and it's not in your PowerPoint, but I mentioned to you about a normal sinus rhythm. There's something called a respiratory sinus arrhythmia. Sometimes you'll see, I had an EMT student last year that said they just refer to it as a sinus arrhythmia. What happens, remember that the vagal nerve, hopefully you remember that is cranial nerve number 10, is the only cranial nerve that goes entirely down through the abdominal pelvic cavity. So what happens when you breathe, you're actually stretching this nerve. Remember again that the vagal nerve is about 75% of the parasympathetic nervous system. And the parasympathetic system is going to decrease your heart rate, decrease the force of contraction, decrease blood pressure. So when you breathe in, you're stretching that vagal nerve, you're stimulating it, it's going to actually drop your heart rate. And so someone with a respiratory sinus arrhythmia, it's really considered sort of a normal abnormal. You'll hear it in quite a few people. You can listen to their heart, and what you hear is lubbed up, lubbed up, lubbed up, lubbed up, lubbed up, lubbed up. So what's happening as they breathe in, they're actually causing their heart rate to drop. While I'm at it, I'll go ahead and mention, I think we probably have already talked about vagling down. That's why a lot of people who are very elderly or otherwise debilitated, they will actually be found dead on the toilet. What will happen, they will have other health issues typically. They're generally compromised in some fashion or the other. And they'll be sitting in the toilet straining to have bowel movement, and as they strain, they're stretching that vagal nerve through the abdominal pelvic cavity, and it's going to be dropping their heart rate, dropping their blood pressure, and they simply pass out. Sometimes they hit their head, sometimes, there's other issues that keep them from waking up. But anyway, that's a phenomenon referred to as vagling down, and you'll find that it's not a rare condition at all. In fact, even Elvis evidently died on the toilet. Okay, I wanted to mention something here called the electrocardiogram, more commonly referred to as an EKG. If you wanted to be more exact, you'd refer to it as an ECG. EKG actually comes from the German spelling of it. So, an EKG refers to a graphic recording of the electrical activity of the heart. It doesn't tell you anything about valvular function or blood flow through the heart. All that's going to take an echocardiogram or sonogram. This is simply giving you an recording of the electric activity. Now, you do need to know a few of the things that are represented on this for the exam purposes. In particular, the P wave, the QRS wave, and the T wave. Now, I'm not going to try to make you guys cardiotechnology experts here, but what you're looking at, and it's pretty easy to draw when you realize that one spike goes up and the following one's going to go down. So the first one is going to be a P wave. That P wave is representing the depolarization of the atria. Now, normally, when something depolarizes, you're going to see it repolarize. However, that repolarization is going to actually be hidden inside of the depolarization of the ventricles, which is a QRS wave. So you're not going to see the repolarization of the atria. What you're going to see, that's your P. Then that's your Q, that's your R, that's your S. So that's representing the depolarization of the ventricles. It's hiding the repolarization of the atria. Come on down, and then you have this little bump, and that's the T wave. So you've got P, Q, R, S, and then your T. And that T wave is representing the repolarization of the ventricles. Now, when you're looking at this, you're going to be looking at this on a piece of graph paper, and when you've been doing this for about 15 minutes or so, you learn that you can actually just glance at this and automatically tell what your heart rate is going to be. Then you measure the distances between these events, and it will have indications from everything of scar tissue to electrolyte issues such as potassium issues, that sort of thing. Don't worry about trying to know this for the exam, but things like the length of the distance between the P and the R wave, or the length of the QRS complex, or the distance between the Q wave and the T wave. Those all have significance to a cardiologist. So again, I want you to know that the P wave represents the depolarization of the atria. Make sure that you know that you don't see the repolarization of the atria because it's going to be hidden inside this, which is representing the depolarization of the ventricles. And then the T wave represents the repolarization of the ventricles. I'm reminded of my own personal experience having an EKG in a doctor's office. Definitely an example of garbage in, garbage out. I knew I was in trouble when the nurse rolls in the portable EKG, and there's the directions on how to hook it up, how to hook up the leads on top, and she's sitting there referring to it. Well, first thing they tell me is I had an inverted T wave, and that can be a sign of a blocked posterior ventricular artery, also known as a widowmaker. So anyway, I got referred into for an echo and all these other tests. As it turned out, when I had the test repeated at the hospital, they had simply put the leads on incorrectly, and my T wave was absolutely normal. So be careful. Now, just to clarify, when I'm talking about the leads, what I'm talking about are the little pads that they put on, and sometimes they've gotten them now where it's just a clip they put on the finger, but traditionally it was this little adhesive pad, and they have what they refer to as 6 leads or 12 leads, and those are measuring the electric activity as it's distributed through the body. So, now I referred to an echo earlier, and an echocardiogram is simply an ultrasound. And what you're actually doing in this case is visualizing blood flow and visualizing valve function. This is the only way you can actually see the valves work, and you can actually see the flow of the blood. They're pretty cool. They're a lot more high-tech than the sonogram that I had when I was in practice. They actually have it where the blood is shown in different colors for if it's, which direction it's supposed to be going, if it's going to be regurgitated or not. So you see this little bit of red flow right here, and that shouldn't be there. Okay, let's move on and talk about the cardiac cycle. And this is something you should be able to think your way through. First off, we're going to give you a couple of definitions. You need to know these: systole and diastole. Think of the S in systole for squeeze. So systole is contraction. It's going to build up pressure in that chamber until it pushes the blood out the valve. Diastole is when the chamber relaxes and the pressure is going to fall. One thing to think about: the faster the heart rate goes, is going to shorten all the phases of the cardiac cycle. We'll talk about that toward the end of this. Now, let's just talk about this from a step-by-step basis here. Atrial systole, what does that mean? That means that the atria are going to contract. At this point, the bicuspid and tricuspid valves, the atrioventricular valves, they are open, and you're pushing blood into the ventricles. So at the end of the atrial systole, you have filled up the ventricles, and the ventricles have as much volume as they're ever going to have. That's going to give you something called the EDV, the end diastolic volume. Now, when we're going to be using these terms, the EDV and ESV, we're talking about what's in the ventricles. Make sure you know that. So it's not talking about atrial volume. We're talking ventricular volume here. So by the time the atria have finished their contraction, the ventricles have the maximum amount of blood that they're ever going to contain, and that is your EDV. Then you're going to end up with ventricular systole. So now the ventricles are contracting. It's building up pressure. It's going to push the semilunar valves open. Remember, the pulmonary and aortic valve. It's going to be pushing blood into the pulmonary arteries and the aorta. Basically, at that point, the ventricles are empty, or I won't say they're empty because they're never totally empty, but they contain the least amount that they'll ever contain, and that gives you a number you can measure as the end systolic volume. Now, the end systolic volume is typically about 40% of the end diastolic volume. So that's going to tell you basically your ejection fraction, or the percentage of the blood that the ventricles were actually able to push into the aorta and the pulmonary trunk. So at the end of ventricular systole, then you move into ventricular diastole. The valves are closed, the ventricles are now relaxed, and you've got the atria filling and getting ready to go. They're basically, you've got the atrial filling during atrial diastole, getting ready to go into atrial systole. So your book has this all broken down and numbered. I think they've got broken down to, like, I believe, 8 different steps. And you need to be able to kind of reason your way through this, and I want you to understand the significance of the EDV and the ESV. One of the things I was just looking at on this chart, unfortunately, I don't know how this happened, but the last sentence of my PowerPoint got eaten off here. What this is meaning to say is at the end of ventricular diastole, the atria are starting to fill. They're actually in diastole. They're starting to fill. The pressure is going up. The AV valves are open, and there's something called passive ventricular filling. So in other words, even though the atria are not contracted, they're not in systole, you still have blood flowing into the ventricles. This basically makes sure that you've got blood in all chambers of the heart at any given time, because you do not want the endocardium to actually stick to itself. So that's very important. And one of the things you'll find, I mentioned earlier that the faster the heart beats, the shorter the phases of contraction, and phases of the cycle rather, And so when you shorten this cycle, what's going to happen is you're going to end up shortening the time that allows for passive ventricular filling, and that means the heart will be pumping out less blood than what it should. So let's look at these terms again to make sure you understand them. End diastolic volume, the amount of blood in the ventricles when they have filled as much as you're ever going to fill. That's right before the pulmonary and aortic valves open. They hold as much as they can ever hold. The end systolic volume is the amount they have in them after they've contracted. How much did not get pushed out? So you can use these numbers to do a computation to give you what's referred to as a stroke volume. So the EDV, the end diastolic volume, minus the ESV, end systolic volume, gives you the stroke volume. Now, a term that you'll hear a lot if you go to a cardiologist and have nuclear scintigraphy, something like that done, where they actually measure the amount of blood pushed out by the ventricles, they'll use the term ejection fraction. If you're a cardiologist, I'm sure there is a major distinction between stroke volume and ejection fraction, but for our purposes, it's not a big deal here. I just want you to know the definitions here, and I want you to know how you come up with this number for stroke volume using these calculations. That's going to give us the stroke volume multiplied by the heart rate is going to give you a total number cardiac output. So cardiac output is the amount of blood pushed out of the ventricles in 1 minute. So because again, you've got your heart rate here, how many times is your heart beating per minute? How much blood did your heart push out when it did beat? Multiply those two things together and gives you the cardiac output. So again, just to reinforce this, your cardiac output, the amount of blood pumped out by each ventricle per minute. So there is your formula. This can be affected by the autonomic nervous system, hormones such as thyroid hormone, ions such as calcium, potassium, all manner of drugs. I talked a little bit a couple of slides ago, back when my slide was cut off at the bottom, and I talked about passive ventricular filling. That is what the blood that's flowing into the ventricles when the AV valves are open, but before the atria have really even contracted. So the atria are still in diastole, but you still got blood running from the atria into the ventricles. However, if the heart rate increases too much, there's less time for this to happen, and that's going to give you a decreased stroke volume, which is going to give you a decreased cardiac output. A decreased cardiac output, if it's severe enough, might actually cause a decrease in blood flow to the brain, which is going to cause you to pass out. The reason you pass out or faint when your blood pressure drops is it puts you in a horizontal position, and that maintains normal blood flow to the brain, because that's the biggest thing. Your body will do everything it can to keep from decreasing blood flow to the brain. Now, venous return, when we talk about venous return, we're talking about blood flow going back to the heart. So anything such as physical exercise or a sympathetic nervous system stimulation, that's going to increase venous return. It's going to be pushing blood back to the atria a little bit faster than normal. And then finally, there's a couple of definitions here I want you to know: preload and afterload. Preload can be thought of as the amount of blood arriving at the heart. So how much blood is going to be going into the ventricles when they're relaxed? How much blood can you possibly stuff in there? So the higher the preload, the harder the heart is going to beat. That's called the Frank-Starling law. So the more blood that you've got, volume-wise, coming into the heart, the harder the heart is going to beat to push it outward. And then the definition of afterload, you can think of it as the amount of force that the heart is going to have to produce to push open the semilunar valves. Remember, that's your pulmonary and aortic valve. So preload is going into the heart, and then afterload is how much force is your heart going to have to create to push the blood out into the arteries. So pretty much that's the end of this chapter, but it's going to flow, no pun intended, into the vessel chapter, chapter 21, and we're going to continue our discussion of arteries and veins and capillaries there. So I'll see you soon. With this chapter, make sure you can diagram the heart. Make sure you can follow the course of blood through the heart. Make sure you can follow the course of the conduction pathway. Make sure you recognize what's happening with the different phases of heart sounds, as well as the parts of the EKG components, and also recognize what makes muscle in the heart unique as far as autorhythmicity and the plateaus and the intercalated disc. And make sure you understand that you've got the two parallel circulations. You've got the atria on top squeezing, and that's at the same time as pushing blood into the left ventricle, is pushing blood into the right ventricle, and at the same time that the ventricles are contracting, you've got blood flowing into the aorta and then blood flowing into the pulmonary trunk. So they're simultaneously happening. If you have any questions, zap me an email or come see me after lab or during office hours, and I'll see what I can do. I'll see you in 21.